Good evening, and at the outset, I'd like to thank the organizers for giving me this opportunity to discuss about the role of the PD-L1, MSI, and TMB in the non-small cell lung cancer. As we all know that there are multiple biomarkers which play into the role in the immune and response. They can be related to the tumor as well as immune system, but PD-L1, TMB, and MSI are the three common ones which are of interest and have a clinical relevance. So starting with the PD-L1, as we all know that the tumor which shows the high PD-L1 expression are likely to show a good clinical outcomes if they are treated with the IO therapies. But for the laboratory purpose, the PD-L1 testing is not as straightforward because there are a lot of combinations which we have to take into account, like the different drug disease combination, there are the platform related issues, and the different cutoffs across the different tumors. So this 3D approach, that the drug disease and diagnostic test, they should fit in together. And the PD-L1 is different from the other biomarkers like EGFR and other driver mutations, which we use to have a very clear-cut positive or negative answer. Here, the things are not as clear. The testing is not only restricted to primarily to the adenocarcinoma. The black and white answer which we get for the other alterations, they are not there. Here we have to do the mathematics, and we have to go with the cutoffs or the percentage values. Expression wise, if you see, the expression also changes with whether the patient is the testing was done at the baseline or whether received any therapy. So if you compare them with the other conventional biomarker, there's a lot of difference, and the problems which we encounter with the PD-L1 testing. Hence, the PD-L1 in a nutshell, we have to see where, in which context you are using. For the clone has to be specific for that particular disease, and even for the specific therapy which is being used. And furthermore, the lab also need to take into account on which platform you are using it. So DACO22C3 Pharma DX is the companion diagnostic assay for pembrolizumab. But if you don't have that assay available, so what will it make it, whether the test will become LDT or any complementary diagnostic assays are available or not. So what is the companion diagnostic assays as compared to the LDT in this context? If we have to go as per the complete assay, and any alterations at any of the steps during this process will make it LDT or not a companion diagnostic. Just to give an example, 22C3 by DACO, if you are using it for treatment with a pembro using DACO platform, it is a companion diagnostic. As at the same time, if PD-L1 SP142 if used for atezolizumab, this is also companion. But if we want to use these assays interchangeably, then it becomes a lab developed test. So we have at least now the four common assays for the PD-L1, out of which Ventana SP263 and 22C3 DACO are commonly used. Because why it is being used? Because of the blueprint phase 1 and phase 2 studies has showed the good concordance between these two assays, and subsequently there are some further more studies has showed that SP263 and DACO22C3s can be used reliably, and they are considered as good as a companion diagnostic assays. Now coming to the PD-L1 assessment of the PD-L1s, or the how do you score it. When we are doing scoring, we have to take into account the expression in these various components, like expression in the tumor cells, immune cells, and then about the scoring, whether you are using TPS or CPS scoring. And there is another score which is being proposed, that is a TAP, that is a tumor area positivity, because it might be easy for the pathologist to score it, but it has not been established. So I'll briefly touch these, how to go about it. The first and foremost thing, when pathologists they see PD-L1 slides, they have to make sure that the controls are working satisfactorily and the sample is adequate. Adequate sample means there should be minimum of 100 evaluable cells in the biopsy samples, and it can sometimes become challenging because that the same sample, same tissue has been tested for other molecular assays. Then assess the number of PD-L1 positive cells, and if you are using immune cells, we have to count only if we are using CPS, which is not in the case of the lung, and then finally give a score. The control tissue which is being used, we use tonsil as a commonly the control, external control, because it gives the variable staining. So we will not miss any positive and negative scoring. Scoring, as I mentioned, there are two types of the scores, like TPS and the CPS. In the lung, we don't use the CPS, but at other sites, majority of the sites you will see the CPS is being used for the PD-L1. So what is the difference between these two? In TPS, we see the evaluate the tumor expression, PD-L1 expression only in the tumor cells, while in CPS the other immune cells, including lymphocytes and macrophages, are taken into account. So then once you have done the staining, then the expression in the tumor cell is red, and as compared to the other markers, so commonly marker like HER2, where the staining is complete, here any sort of staining is considered as positive. So it is not only we have to see the strong and diffuse positive staining, and then you divide these cells with the number of the viable cells to give the TPS score. And so TPS is used if you are using 22C3, but if you are using Ventana, then better to give the percentage of the tumor cells expressing. Both are having the same meaning. There is no difference between the two. Any staining which is above the more than 1% is considered as positive, and high expression is considered when it is more than 50%. Just to show you a few examples, like this is a very strong and diffuse clear-cut positive in more than 90%, and this is another example showing a negative case. You can see there is no staining, but all these cases, before we call it as a negative, it is recommended to see the slides under higher magnification at 20x, because even the 1% is considered to be positive. Another thing, cautions we have to take, especially when the staining is weak, and not to account macrophages or immune cells into the staining. Another important thing, when we interpret them, we have to take into account that PD-L1 can be heterogeneous in expression, and we have to include both areas of strong as well as weak positivity when we are giving the final score. So finally, when we report, or as an oncologist you see a report, these are the information should be conveyed by the pathologist. First is about the nature of the biopsy, and whether it is adequate biopsy sample is there, the type of the clone which is being used, and also the platform which is being used for the staining, and then finally coming to the results, like positive or negative, and with the specific mention about the cutoffs. Therapeutic option indication, it is not a mandatory, but it is an optional thing which can be off. Just to share about our data, although it is a little old data, but now the request now the PD-L1 is asked in almost all the cases, and the lung is the one most commonly being used, and the positivity rate for the PD-L1 is around 61%. So this is one marker which is very highly expressed, and if you see the further split up, the very strong positive of the cases which show more than 50% of the positivity, they are roughly around 20%. So the positivity rate, especially are comparable. All the overall positivity rate in our cohort was slightly higher as compared to other studies, but the positivity rate more than 20%, more than 50% is around 22%. So this is about the PD-L1, and what are the other alternate biomarkers beyond that, and the important one is the TMB, which has been used in many trials. And excuse me, can you please be silent? So why TMB has gained the relevance, because in addition to the PD-L1, we have seen that the TMB is also being used as a cutoff across various studies. But if you see the analysis of these TMB, so we need to have a very large panel of NGS for the optimal evaluation of the TMB. Only then we can get a good and clear-cut information about the TMB. And there are two methods how we can report the TMB. Either one is the whole exome sequencing, which practically is not feasible in the clinical utility, so the targeted panels are used, but we have to keep in mind that we should use a panel which has a gene minimum of 300 genes should be there, and the panel should have a coverage of at least 1.2 to 2 megabase pair of alterations. And also in addition to the size of the TMB, another important thing which we need to consider is about the cutoffs. cutoffs are all for TMB are also variable. So again, that is a problem because various trials have shown that there are various cutoffs, some based on the mutations per megabase, some based only on the alterations. The Foundation One medicine, which is commonly used panel, they have put a cutoff of 10 mutations per megabase pair, and you can use either 2-tier or 3 tiers of classification for the TMB, like more than 10 mutations per megabase, it is a high TMB, and less than 5 is so in addition to that, the bioinformatic analysis is also a little more challenging. So that those are the reason why the TMB has a limitation when we are using it for the routine clinical practice. So we need to have everything in place and so that the analysis can be completely done and the report can be really reliable. And there are now studies coming for the assessment of the TMB even on the blood. And last, I'll just like to touch upon MSI. MSI is commonly used in other sites, especially in the GI tumor, but in the role in the lung is still not clear, and now, so that's why it is not being commonly used. And another thing, it consumes a lot of tissue also at one go. So there are some methods to evaluate MSI by using the molecular or NGS. So at the same time, you get information about the TMB as well as the MSI. But for PD-L1, you have to go and use the immunohistochemistry as a diagnostic method. So just to summarize, the PD-L1 is still the best available validated methods, and the role of TMB and other modalities is still under investigation and has a limited role for decision of immunotherapy. So with this, I thanks for your kind attention. So I'm sorry, I have to literally rush because 10 minutes was very small to cover this topic. Any questions or any queries?